Good evening, ladies and gentlemen. Welcome to our first Temper conversation for this year on hypertension. Please accept my apologies for not being able to switch on my camera, but we currently have load shedding in my area. So my name is Jacqueline Lowe. I am the team leader in our wellness department, and I want to thank you for taking the time to attend this session and trust that you will find this session informative. Our speaker will present for about 45 minutes and we will have a questions and answer afterwards. You're welcome to ask your question in the chat box during the presentation, and Sister Thandi will address your questions after the presentation. You're also welcome to raise your hand at the end should you wish to ask your question. It is my privilege to introduce our guest speaker for tonight, Sister Thandi Bukali. Thandi is an occupational health nurse practitioner with over 15 years within the public and private sector. She has devoted herself to the study of unique, scientifically sound solutions to modern health issues. Over and above her occupational health and nursing qualification, she holds a PMB qualification from GIBS, currently a MPhil International Business Candidate at GIBS, as well as a member of Toastmasters International. Through nature of work, she does have co-partnered with a number of corporates to offer wellness education across the landscape and has been able to coach scores of audience with her passion for wellness. Thandi is the General Manager of Specialized Clinical Services Division and a member of the Executive Committee at a Gauteng-based private health and wellness organization. So welcome, Sister Thandi. We look forward to your presentation.
Thank you so much, Jacqueline. It's a pity we cannot see your pretty face. Load shedding, has put us in a corner this few years. But thank you so much. I really am delighted to be part of this platform, and load shedding just hit me as well. So let me try and turn off my camera so that I can save whatever bandwidth I have for myself to be audible. But as I was just saying, it's such a privilege and an honor for us to be a part of this platform to talk about health-related issues for this particular topic tonight, hypertension, which we also call a silent killer. As you would have heard, that we gladly involve ourselves in any platforms to engage on solutions that are regarding healthcare or wellness or anything basically that has to do with health. And we do this realizing that many organizations and the approach generally out there tends to offer a patronizing approach of a tick box and nature basically in terms of healthcare solutions. But we often want to get involved to say, here we are engaging with you, here's the information you have and that you can use that is available at your fingertips to make sure that when we leave these platforms, our clients are empowered, inspired, and resilient. A current study that was portrayed or that was reflected by International SOS sometime last year depicted that globally, 88% of healthcare professionals are really anticipating that there will be an evolution around healthcare needs. And on top of those newly envisaged healthcare needs, you would find things like mental health, chronic related conditions where hypertension forms part of, and a few other things. And we know that whatever numbers that we are looking at are probably quadrupled if we should reflect and see what the statistics are currently saying, because we know and we understand that the impact of COVID-19 literally changed everything. It reduced access to healthcare facilities. It reduced the ability for preventative and training related approaches to be offered to a larger population of people that we would perceived at high risk. So with that brewing in the background, we definitely do know that even part of the statistics that I'll speak about tonight around issues of hypertension are probably 2 or 3 times what we're talking about. So There is a gentleman by the name of John Sanei. He's a future strategist and a global speaker. I really love, his perception on a whole lot of things, and particularly around the COVID-19 era. He phased that entire era as an era that has three categories: the sad, the strange, and the adventure. And he mentions that in the sad stage is that was just basically categorized by the beginning of COVID-19, where we saw a lot of deaths, a lot of people getting admitted to hospital. And around the strange stage, it's when we were trying to really get a grasp around our so-called new normal, but we're not yet really out of the woods at that time. Our adventure stage would probably be where we are now, where we can walk around with no masks. We hardly ever see anything broadcasted around COVID-19. But all of those three phases had a dire impact on the hierarchy of needs, which Maslow's hierarchy of needs reflect in this particular slide. We know that people were affected, their basic needs, the bottom layer there was affected for many, many people, and when they lost their jobs and lost the resources that they had basically to provide for them. Some, it was safety needs. As I just personally said, some lost their job, some lost their loved ones. They never even had an ability or time to recover from losing one loved one to another because of how the COVID-19 area basically was, with people dying from left, right, and center. And I'm sure you and I can relate with one or two layers of this need that was shaken when COVID-19 was at its peak. And I'm speaking about this because it's an important message to drive from or to work from with any other solutions that we put on the table, be it healthcare, be it, whatever solutions that we put on the table for our clients. We start here so that we can be able to know what has exactly happened. Right. So for our discussion tonight, we're talking about hypertension. What is hypertension? Some people call it high blood pressure. Well, a medical term, we call it hypertension. This is a condition that's basically categorized by an elevated blood pressure reading that would have the top number. This is how I basically explain it to my patients. The top number would be equal to or over 140, and the bottom number would be equal to over 90 millimeters of mercury. And this particular picture needs to present on 3 separate occasions where this reading is done. And it would have to be at least in a minimum of 2 days apart from when the first reading was done. And you could be monitored, and then we'll see where exactly do you sit. By the end of the 2 days, after 3 separate occasions when the reading has been done, we'll get a good picture of where do you see it, based on the categories that you would see on the top of the slide. Are you on the amber area where it's just pre-hypertension stage, which could be stage 1? Are you really at a high blood pressure stage or at hypertensive stage, where we could start exploring some certain management approaches to try and contain the situation? Or are you in a hypertensive crisis where immediate consultation and referral needs to happen to manage the condition? So basically, this is how we try to explain high blood pressure or hypertension. And lastly, the last other thing that we mentioned that this phenomena occurs because your blood vessels would have been exposed to something that has made them to constrict, reducing blood flow to reach other vital organs in your body. And those risk factors could be one too many. Now, statistics shows basically that in South Africa, when it comes to demographics, and I would love to split this statistic in another time, but basically just at the surface, you can see that most females are diagnosed with high blood pressures compared to males. And it could be a whole lot of things. You will see when we speak about risk factors, how this basically leads to the numbers that we are sitting with here. It would be nice to split these numbers to see where exactly are these females sitting? Are they still within employment stage, or are they, at an elderly age, or where exactly, so that all the interventions can be targeted and can be directed to the right particular groups. We also see that statistic tells us that hypertension or high blood pressure is one of the key catalysts to conditions that lead to death and disability in South Africa. It is estimated that cardiovascular as well as cerebrovascular diseases amount to 1 in every 6 deaths that we see in South Africa. That's a total of perhaps 225 deaths per day, basically, that are accounted for. And when I mention cerebrovascular, I'm talking about stroke. When I mention cardiovascular related conditions, I'm talking about heart attacks and so forth and so on. But in many, many instances, the catalyst would have been hypertension. Globally, we see that this phenomena accounts to about 7.5 million deaths, which is about 12.8% of the total deaths that we see in statistics that are being reported. And hypertension, as I just said, attributes to about 54% of the type of strokes and type of heart diseases that we see, right? And then I looked at this particular statistic that was looking at 10 leading deaths in South Africa. Even though this journal was focusing around interventions on tuberculosis and other conditions, respiratory related conditions, it was intriguing to see that already, your diabetes, cerebrovascular diseases, other form of heart disease, hypertensive diseases are already featuring on the top tier of this statistic, which shows you that this is basically a ticking time bomb. In every layer, there is somewhere and somehow where hypertension could be, brewing a storm one way or the other. Now, when we look at what could be the causes then, or what are the risk factors, I'd like to call it risk factor because we can be able to apply quite a whole lot of techniques to ensure that, the results are not as dire as the other previous slides that I was presenting reflected. There's many, 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 reasons why people could be exposed to high blood pressure. As you would imagine, when I was reasoning that high blood pressure is basically anything that puts pressure on your blood vessels, reducing their ability to be able to send blood in most vital organs in your body. With some people, this could be caused by stress. When we are stressed, there is another level of vasoconstrictions that happens in our blood vessels, which means our blood vessels constrict, and then that leads to the blood pressure being raised, basically. Your genetics, and I'm mentioning this in no particular order or in no logical sequence. Your genetics, it is likely that if you are born from a family where high blood pressure is common, it is likely that you may end up having or exhibiting symptoms of high blood pressure, which is why when we look at family history, we will often advise you to always keep a look and see what your blood pressure looks like. Gender and age, you would have heard me mentioning this when I was speaking about mortality rate and the diagnosis rate in the previous slides. That seems to also contribute there. Sedentary lifestyle. Most of our corporates, or the type of work we do and largely had to do when we moved to hybrid working approaches and when we moved to working from home, was basically sedentary work in nature, which means you are sitting behind a desk on the chair in front of your computer for hours and hours. And this lack of physical inactivity leads all the way back to the top point on the left part of my slide, which is obesity, basically. So those two are intertwined in one way or the other. Our dietary habits, one could almost imagine that each and every time we are stressed, we tend to eat differently than when we are not stressed. each and every time where we have to spend long hours in front of a screen, pushing work and pushing deadlines, we are likely to eat whatever our hands can find. And often that is not necessarily as healthy as we would like it to be. And before you know it, we're gaining a few pounds. I'm still fighting off a few pounds from the dumplings and the stews that we cooked up when lockdown started. So I hope nobody judges me, because it was our way of coping at that time. Things were tough. So one way or the other, you find that you lead all the way up to a point where you've gained a few kilograms, and you need to deal with that as well. Some of the two reasons that are not explicitly mentioned on this slide is basically our lifestyle or habits, like smoking. That also tends to cause your blood pressure to raise. The nicotine that is found in whatever that we smoke tends to cause or exacerbate the picture of vasoconstriction in the body, which results in high blood pressure. The one last factor that's probably not mentioned here is pregnancy. We do know that there are certain people that get exposed to hypertension during the period of pregnancy, and as soon as they've delivered and gone back to normal, hypertension is in history, basically. So those are just some of the risk factors or the causes that gives us a picture where one has hypertension. The last one I can think of is other medical conditions like Cushing's syndrome or a thyroid problem. So there's really plenty of things that could lead to a person being hypertensive. Right. So what do we see then? If you haven't been diagnosed with any of the conditions that I've mentioned, if you haven't even gone into detail in terms of what your genetic and family history looks like, what would you see as signs and symptoms? Besides just an elevated blood pressure reading, you will often complain of headaches. For most people, these headaches often present in the mornings as well. You will complain of dizziness in other instances. You'll complain of blurry vision, and it's important to establish where that is coming from. As you can see, the symptoms that I'm mentioning are as vague as anything else. So it is important to always go a step further and really try and find out what exactly is happening. What are these symptoms that I'm presenting with attributed to? And obviously, when you do a consultation, the first and foremost things that will be done at a clinic level or at your GP is that they'll check your sugar, your blood pressure, and all those kind of things to see what is exactly happening. And the rest of the other symptoms will also show up as and when the condition becomes severe. It basically depends on how early you found out about it and how it's presenting itself. Right. We often talk about treatment modalities. As a nurse, our focus is often that of prevention is better than cure. We want to be able to make sure that we manage a patient at a stage where we can still do a lot with our own hands before we introduce our counterpart on the right part of the slide, which is your pharmacological action. But as you would have seen in my other previous slide when I was talking about categories of how severe or how moderate the blood pressure readings could be, that already tells you that the approach in treating each case will vary. As you would have seen as well in terms of risk factors, how varying factors were presented there, it will also tell you that there is a variety of approaches that could be adopted in treating a person that has basically hypertension. One of the first and foremost things or messages that I push when I sit with my patients is start the conversation. We've spoken about a lot of things on the risk factors that I'm going to repeat and see how you correct them here. But I often say start the conversation by visiting your doctor or by doing regular screening. It is in that platform that you will be able to, one, know what is your normal, because your normal may not be the same as my normal. It may not be the same as the other person sitting next to you's normal. So it is important, and you can only be able to do that if you have already started seeing a clinician and have your blood pressure measured, and then you can be able to see, oh, okay, so I pretty much sit around 120/80 when I'm feeling okay. And you will see that these numbers tend to change here and there. I know in the previous slide, I was speaking about a hypertensive or a pre-hypertensive stage starting at 140/90. On this particular one, we were promoting that people should look out and already start putting some action when they're sitting at 130/85. Start knowing what your numbers look like in totality. You would have heard me talking about cerebrovascular disease or cardiovascular conditions, and those would be accounted for by things like your sugar levels, things like your cholesterol levels. We look at the total picture of your waist circumference, because that speaks to obesity. And all these numbers, the more you get used to it, the more you get to understand what works for you, the more you realize that, you know what, all my numbers are okay, but what is more troublesome on my side is the BMI. I'm way above 30 or above 40, which is regarded as morbid obesity. Then I need to work on killing those kilograms down, because even though everything else looks okay, I don't have any headaches, I don't have any signs and symptoms that were referred to in the previous slide, but my body mass index is exposing me that should I get stressed or should I be exposed to an illness of any sort, my blood pressure is probably one of the first things that is going to shoot up. So that is why I promote that approach, because it really gives you an approach where you hit a lot of birds with one stone. If you are probably looking at your BMI as well, you know you need to increase your physical activity. If you'd be probably looking at what you call cholesterol, basically being one of the factors that are high, and blood sugar, we know that, like it is said in chemistry, that where water goes, salt follows, or is it the other way around? But that analogy plays the same picture here when it comes to hypertension. If there is hypertension, it is likely that in the near future, blood sugar will also drop in there, or cholesterol will also drop in there. So take care of yourself, start having these conversations. You can even schedule this and make sure that once a year, you do these kind of measurements, or often depending on how your picture looks like in terms of risk factors that we mentioned earlier on. On the right side, then, when the picture has worsened and there is very little that you can do without the help of a pharmacological participant, there are a few things that the doctors will look at before putting you on medication. They will look at age, they will look at pre-existing conditions, they would look at a whole host of things before deciding what is it that's going to work in your condition. Which category are you? Are you already in crisis? Are you somewhere moderate? And they'll be able to decide, is it one drug that's going to help? Is it a combination of 2, 3 more, and so forth and so on, over and above the rest of the stuff that you will be doing that falls under the non-pharmacological category. They give you drugs that are called diuretics. It happens that when we have blood pressure, sodium, which is the salt in our bodies, tends to be retained, and when it's retained, there's more water that is also retained in our bodies. That also affects how blood will flow, or how our vessels will be patent, allowing proper blood flow. So they'll probably give you diuretics, which will reduce that and drain all the water, drain all the salt along with it, to allow your body to function properly. And this particular type of treatment, you will often be advised to drink it during the day, because obviously if you drink it during the night, it will cause you to wake up quite a number of occasions to go to the loo to drain the water. The other form of drugs would be in the category of angiotensins, and those also basically vary. There will be one that they can diagnose, that can prescribe for you, which will help try to reverse the condition that basically takes place in your blood or in your blood vessels when hypertension happens. There is a certain chemical that forms that causes your blood vessels to constrict. If you are stressed, as I was mentioning, if you are exposed to nicotine, if you are exposed to a whole host of other things, there's a certain chain reaction that happens to produce a chemical that will constrict your blood vessels. So this part of angiotensin group of enzymes will try to make sure that this chemical does not form at all. If it happens that your situation is a little bit worse than that, the chemical has formed, it is not easy to reverse this process, then the doctors will add angiotensin 2 receptor blockers as your form of treatment to try and disable this particular chemical that keeps on constricting your blood vessels not to work. If that doesn't work as well, they go to the next plan where they'll give you calcium channel blockers. This will then help to try and make sure that your blood muscle, your blood vessels muscles relax regardless of what's happening. And then the dosages will vary, and there's a long list of other treatment modalities that can be brought into the picture. You will hear about alpha blockers, beta blockers, alpha beta blockers, vasodilators, and a whole host of other names that you will hear. But all of these pharmacological actions or interventions are brought into the picture to try and correct whatever that could be happening given different cases at a time. Right, but back to the left part of our slide, prevention is better than cure. Whether you've already been diagnosed with a blood pressure related condition, whether you have family history, my encouragement and message always goes back to keep on seeing your numbers, start your conversation there and see where it leads you to. It will help you to have a more targeted approach because each of us present with different pictures at a time. Right. So what could happen then? Should it happen that we do not look after ourselves or we do not get the opportunity to know about this silent killer in time? There are other, situations or cases where we find that the person really did not present with severe symptoms that I was speaking about earlier on in the presentation. They really hardly recognized or remember having severe headaches. They can hardly remember, an incident where they had a nosebleed or where there was urine in their blood, and urine in the blood basically will be picked up when a urine test is done, and through a dipstick method, we can be able to pick that up. So if it happens that this particular person was never given an opportunity or never had an opportunity to see all those signs and symptoms, they can always end up presenting with a very severe case. Or they have been seeing the symptoms, but have perhaps been neglecting them or not understanding what they could lead to. But it is conversations like these that enable you and I and our friends and our loved ones to know that you don't just sleep over a headache that's not responding to Panado. You don't just, carry on as if it's business as usual when you do see that you are wearing spectacles, but your vision is still not improving. So it's platforms like this and education like this that helps us to basically dig deeper in that. Or if in the last case, the person was given treatment, not adhering to treatment or not responding to treatment, what could be the complications that we would be looking at? It would be heart attack or stroke, as I had mentioned earlier on. It could be an aneurysm, a ruptured blood vessel, basically in critical areas of your brain particularly. It could be heart failure. I spoke about weakened blood vessels. This is largely around your kidneys. It could be a lot of things that could happen that could end up leading either to death or disability, as I have mentioned in my earlier slides. So it is really important that as much as hypertension or high blood pressure has become such a household name, that we understand the impact that this comes with if it is not detected early, if it is not prevented in time, if it is not treated adequately, what the complication could basically look like, right? Now, As we sit in this platform, basically, all the people that I would have mentioned in the risk categories, whether male or female, when I was speaking to mortality rates, whether people who are employed or are at home, the reality is that you and I know someone somewhere who could easily fit in that category. And we often see this picture as we deal with corporates or deal with employers, that there is a high incidence rate in terms of presenteeism that ends up being absenteeism because of people that have to be away from work due to this particular condition, amongst other conditions. As you would generally know, depending on whether you're using a private sector or a public sector to access your treatment, once in a while you are required to take some time off and go and get a new script and get your treatment. So this message is now particularly maybe relating to anyone who could be a manager taking care of a group of people that could be affected, or generally employers who might find this also relevant in their setting. So that these people will have to go out and go get treatment. If you do not have the luxury of a clinic in your workplace, it means time away from work, because by the time they are done with their doctor, it's 12 o'clock. Some of them will probably not come back to work or whatsoever. And depending on when they are in terms of the categories that I mentioned, some of them may even need a few more days away from work to contain the situation of their hypertension, or to perhaps help the body transition into the new medication that they've just been given, an additional drug that has just been introduced. As you could see, the list that I was going through in the pharmacological action, but we know without a doubt that that particular picture, creates an unmendable bottom hole, in the company's bottom line, basically, because that kind of absenteeism or presenteeism is difficult to manage. It's difficult to quantify. Stats SA was saying in 2018, presenteeism that led to absenteeism amounted to approximately 12 to 16 billion rands that was affecting South African corporate companies. So there is no way that in a solution or in a approach to tackle the issues around hypertension, employers cannot be brought, into the picture. We know that we generally spend a third, if not more, given our hybrid approaches, doing work-related stuff. So one way or the other, it would be impractical to think that we can apply preventative measures or solutions that will leave out what's actually happening at work. And you would have seen in some of my risk factors I mentioned that part of the exacerbating factors are a sedentary lifestyle. It is stress. Many employees are reporting to have been stressed during this past 2 years, more or twice than they have been before the COVID-19 era. And it is important to acknowledge that, because it takes us back to the first slide that I spoke about, that Maslow's hierarchy of needs, that pyramid. Many people have had that pyramid distorted or turned upside down because of the nature of where we work or how we work, and just general situations around us and other dynamics, obviously, that are accounted for in our personal lives. So it is important, I felt it is important that we also include what things could we as managers, as employers, or as colleagues look at when we have a colleague or a person in the workplace that might be suffering from this kind of condition. And lastly, one of the key things that is coming up due to research that is surfacing is that chronic stress is becoming the leading cause of chronic hypertension. I mentioned a few risk factors in the other slide, but it is appearing that chronic stress-related hypertension is topping the charts. So we definitely need to do something about that. Just perhaps in the same breath as I was saying, we cannot deploy solutions and approaches to tackle the issue of hypertension without including our workplace dynamics. It's almost the same as saying that we cannot tackle hypertension-related issues without including work-related factors as well as mental health-related issues, as you can see the chronic stress there. Let me go to the next slide and unpack this a little bit more. What then this means, over and above the non-pharmacological actions that I have advised our attendees to focus on, which is focus on your diet, a good diet, know your numbers, be physically active, adhere to treatment, attend your follow-ups, do this, do that to change the picture. Employers could really step in understanding their demographics in the workspace, basically. Who is your workforce comprised of? Because this will help you understand if the larger population of your workforce forms part of the people that are largely exposed. Let me say, for instance, if your workforce is formed of 50 or 60% females, you would have seen my other slide that said that as females, we are more susceptible to, being diagnosed with high blood pressure because of the nature of stresses and a whole lot of things that our bodies go through to put us in a situation where we end up being obese. And it sounds like an excuse to be obese, but you know that you can relate with it. So then as an employer, and say, hang on a minute, what do I do in this particular situation? You can see that the number of female workers you have are all within childbearing stage. So some of them will start using certain type of contraceptives or are on certain methods already. That also plays a role in changing their blood pressure. The pregnancy issues that I was relating to, it gives you basically a better way of viewing what type of interventions can be put in place to assist your workers. If the nature of work that is being done on its own in that particular way of employment is stressful in nature, you know that it is likely that one way or the other, you may end up having employees who are suffering from this condition. How do you support them instead of exacerbating the issue? Obviously, this first line in understanding your demographics will help you to either develop a philosophy around health and wellness or redefine it if there's already one that's existing, because now you will be mapping each dot to the relevant party to make sure that your intervention speaks to what you are sitting with, right? We also often encourage and assist employers as well as managers, as well as different types of platforms to continuously do a gap analysis and look at what do our policies say around sick leave, around disability, around, absenteeism? What do our processes look like in terms of what we do day to day, as I was speaking earlier on the first point of demographics? What programs do we have in place? I mean, some employers have made the best decision ever to have Bestmed as their service provider in terms of, medical aid and other related solutions, because it is essentially because these kind of things were picked up. And as an employer, you want to be on top of your game and make sure that, there's programs that cater for things like this. We do extensive work around wellness day drives where we assist employers to encourage employees to come through, have the first conversation that I was referring to. Get your numbers checked out, know what your critical numbers look like. And then from there, the conversation is free from stigma. It's free from, pushing back. It's free from any other form of attitude that would hinder progress. It makes things basically easy. And I know of one particular client that we assisted that just comes to mind now, where an employee suffered high blood pressure related issues, ended up with a stroke, was booked into disability. We saw that process happens, without fail, booked into disability, be rehabilitated back to work and reintegrated into an accommodative or an alternative position to ensure that this employee can still preserve, whatever amount of lifespan they have left, and they can still be of benefit in the workplace. And again, I am mentioning all these things because most of the times we speak about diet isolatedly when it comes to hypertension. Drop the salt, drop the fat, drop this particular type of food. We speak about lifestyle-related habits. Quit smoking, quit alcohol, quit this particular type of thing. Isolatedly, we speak about risk, all those risk factors without really looking at a bigger picture. This person that is presenting with so many risk factors, where do they spend most of their day? In that environment, what are the changes that can be made? I think for the benefit of entertaining questions and answering questions, I would like to stop here and just quickly be able to reflect and see if there's any questions that we can quickly tackle and move on and make better use of time. So Jacqueline, let me hand over to you to take us through the questions.
Thank you, Sister Thandi. The first question that we have from Futsimo Demo is, can stress be genetic?
Yes, as I mentioned in one of the risk factors, genes could account for this. I know there's a discussion that keeps popping out to say whether is it really genes or is it a way of being socialized in the family. Like for instance, when you find that you are coming from a family that eats a lot of braai vleis, a lot of chips and acha and it is almost common to think that when you go into your own household, you will also tend to revisit the same type of food groups because that's what you've been socialized from. However, yes, genes can be a contributing factor to how we respond to certain situations and how we present with the picture of hypertension.
Thanks, Sister Thandi. So far, that was the only question we have.
Okay, all right. I saw a few activity in the group, but I do see that it was mostly email addresses for people who were joining in. And basically, that's just that. Basically, that is that from my side. If we do have a minute or two, I could go back, revisit one slide or so, but let me hear from you, Jacqueline, on how you would like us to proceed.
Okay, we just have Almarie. Do you want to say something?
Yes, I want to say something. I'm Almarie Jooste, Executive for Client Service and Wellness, and unfortunately, Sister Thandi, I joined late, only a few minutes ago, and I must congratulate you in the way that you presented the data and the information to us. Even I could understand it, which is a very, 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 it's not always the case. And we really appreciate it. We will, and I'm now on dangerous grounds, share a copy of the presentation with everybody that attended the meeting, if that is okay with you.
We spoke about that with Jacqueline in the beginning. I am sure that since it is recorded, we just need to cross all T's and dot all I's on our side as to what is the limitation in terms of time on how that can be basically shared, but we'll probably get back to Jacqueline with that, so it shouldn't be a problem.
So,
all right.
That's all I needed to say, but thank you so much. It was really a good presentation.
Thank you so much, Elmarie. Lovely to have you. I see there's a question from Salfi. Salfi is asking, can you please revisit the numbers and what they mean? Let me try and get back to the slide, this particular one. Sorry for scrolling like a maniac. Okay, so here is what the numbers look like, Salfi, in terms of your blood pressure. Ideally, by the book, your normal blood pressure should be sitting at 120, which is your top number, over 80, which is your bottom number. But this really varies based on a whole lot of things that I may have not mentioned for the sake of time. For instance, you find that people who are very, very tiny in stature, their normal blood pressure is around 110 over 70. For instance, I remember when I used to be a size 6 and I was still tiny and twiggy, 110 used to be my normal reading. As soon as my blood pressure comes up to 120 and 80, I would already start experiencing dizziness or, blood vision or headaches. It was most commonly headaches. So that there are those considerations to look at. These over here are numbers that are used for universal referencing. So we call by the book a normal blood pressure to be 120 over 80. And when it starts being elevated, it starts escalating all the way up to your 130s over 80. For a pregnant woman, we already start screaming when they are sitting at 130 over 90. For a blood pressure reading of 140 over 90, we start having really serious conversations, because now we are going to want you to come back to get at least 3 more separate readings on 3 occasions, to have this done within a period of 2 days, so that we can establish whether do we now really have to refer you now for treatment, or what needs to happen in your picture. And in other cases, you find people who would be presenting with the last bar of readings, which is 180 over 120 and above. At close to 200 on the top number, we call it pre-stroke, but that is where we know that definitely you're not working away without a tablet or 2. So this is basically what it looks like. You will also find that the normality in these ranges changes for people who have never been diagnosed with blood pressure versus people who have been diagnosed with blood pressure. If I've been on blood pressure medication for a few years or so, or for some time, and now my blood pressure with treatment sits at 140 over 90, I am considered to be doing very, very well, right? And not at risk, because at least I do have a second leg of pharmacological action that's helping to contain the picture. Whereas in a different scenario, if you did not have treatment and you're showing up with those numbers, we will start screaming help. The other section that I was speaking about, Salfi, of knowing your numbers and understanding your numbers, is on the slide over here, on the left part of my slide, that picture that we have there. There's, unfortunately, I don't think you can see everything that's written in smaller numbers, or maybe it is just me, but the first numbers, the critical numbers to know in your life, is your blood pressure reading. Here we are referring to about 130 over 85, which is still between the borderline or numbers that we referred to earlier on. You need to know what your waist circumference looks like. You need to know what your cholesterol readings look like. You need to know what your blood pressure reading looks like. You need to know what your body mass index looks like. And I am mentioning these critical numbers here because on risk factors, we mentioned that some of the situations that exacerbate the picture of hypertension is existence of other conditions, cardiovascular conditions, so we call them. And those could be your cholesterol and your blood sugar related conditions. Some of the factors that exacerbate and puts you at risk of having a high reading in terms of your blood pressure is if you are obese. And you will know that you are obese if your body mass index is all the way above 25 and so forth and so on. It goes all the way up to morbid obesity at about 40 and above. So if your picture has some skewed numbers in terms of these that I have mentioned, then it helps you to know basically where to start your conversation, right? If it is BMI, you know you have to work on dropping the kilograms, your weight. If it is blood sugar, you know you have to watch out on what you're eating, your sugar intake, and so forth and so on. As well as your cholesterol, you know you have to watch out on certain key things in your diet. If it is your waist circumference, it's almost similar as what you would do with the body mass index, because you have to lose those centimeters. And the reason we look at waist circumference is because studies show that most cardiovascular conditions are prevalent around people who have more fat around the waist. And this obviously puts us in a bad corner as females, because after having a few kids or so, you know, our waist is really no longer what it used to be, you know, and there's a whole lot of factors that we need to consider as well, because based on, how do I call this, ethnography, you will find that the measurements tend to vary. I spoke about family history related factors earlier on. If your body mass index says maybe you are 35, but when you measure your waist circumference, you find that it is lesser. You may find that in terms of fat percentage, you are not at risk, but because you are big boned or you are taller, that's what is basically escalating your numbers. That is why I like those conversations to take place around your critical numbers, because it will give you more insight on a whole lot of other things. And you find that you end up deploying an approach that will have a domino effect. Basically, you hit one tab and it hits the entire 100 tabs, and your solution, you know, is more effective. I hope I have answered you, Selfie. Otherwise, you can indicate perhaps, you know, in the chat box or something like that. Right?
I'm sorry, I just want to say that if you're not, please stop talking about being overweight, because if you're not going to stop, we're going to cancel this session and not ever invite you again.
This is me stopping. I am stopping right now, I promise you.
Sister Thandi, we've got a couple of questions here. How does age reflect in this issue?
Okay, so age reflects in various ways. You will find that we have quite a few cases that we tend to pick up with abnormal blood pressure, especially around, you know, your early adulthood, where, you know, a normal human being transitions from high school or tertiary into the workplace environment, and there's more responsibility, more pressure, and more, you know, accountability that is required of them. And they're starting to stay on their own, they're changing their diet. There's just basically, you know, a lot of things that people are now really starting to face in real life. So you find that there are a few numbers that we tend to get there, but those are very quick and very easy to change and manage, because just by applying preventative measures to that particular young person's life, you can be able to change a few things. You also find a different group of, you know, age-related conditions that are to do with blood pressure around the childbearing stage, as I was mentioning earlier on, that you find that a group of young people who are starting to use contraceptive methods have to basically hop from one method to another, because, ooh, I started with the pill, but it's giving me a headache. Now I have to change to something else. I started with the injection. It's not really treating me well. It's, you know, making me to do the other condition that the other participants said I must not mention by name. So, you know, I mean, I still want to be part of this platform, so I'm not going there. All right. So there's a lot of things that could happen based on each age group. And then later on, you tend to find that older people are dealing with basically a different type of problems at that stage. You find that we do this in corporates as well. We tend to see that there is a demographic that is represented by people who are at a stage where they are managing teams. There's more responsibility, there's more pressure with the job itself and the load that they have to carry in managing that entire team. Those are some of the people that you'll find represented in those particular age demographics. So it really varies, but it's never age alone. As you can hear, it would be age, it relates to stress. It would be age, it relates to diet. It would be age, it relates to a certain medical phase or phenomena that a person is faced with. Let's move to your next question, Jacqueline, with the remaining minutes.
Sure. Once one has adopted a good diet and takes medication religiously, does hypertension ever get cured?
So remember, these are just 2 or 3 of some of the things that the individual is doing. Based on what you found out when you're doing or you're revisiting your numbers, you would know and understand whether was your contributing factor stress. Was your contributing factor perhaps smoking? If those are not there, if there's no attentions basically that are interventions that are put in place to attend to that, then it's likely that you will eat well, you will stick to your diet, to your treatment, but you find that when you are stressed, your numbers go up again. Right? So it's a holistic picture. If for your case, it was the BMI that was exacerbating the issue, so probably these two will help in the long run and get you in the right track.
Which fruits and vegetables are best for lowering blood pressure, or should this be referred to a dietitian?
Absolutely refer to a dietitian because it will vary from one case to another. But, you know, on a normal case, the general fruits that we all tend to eat, apple, banana, and all those kind of things could be okay. But a dietitian will help you map what really relates to your to the severity of your condition as well.
Okay. I just want to add quickly on that for all the Bestmed members, if you do your health assessment at any Dis-Chem or Clicks pharmacy, you get 3 consultations with a dietitian that can assist you with a personalized diet plan. So if you want more information on that, you're welcome to email us at tempo@bestmed.co.za and we can explain the process to you. Another question, can the blockers cause skin blisters?
Can what cause skin blisters? You've got cut off.
Blockers.
Okay. Look, it's difficult to just say yes from the shooting from the hip. Have that looked at properly and see what is happening. I do know that there's some medication that we get to review that causes patients to cough a lot at night, but that's often in cases where when the patient is not really responding to the type of treatment we put them on, and we need to revisit a few things. So if you are experiencing that alongside or just when you have started new treatment regimen, revisit it with your doctor. It would be very unfair for me to say a bold yes to that.
Okay. Can blood pressure be hormonal and cause headaches after menopause?
Yes, we do know that that's one of the things that we see when people are at premenopausal, menopausal stage and postmenopausal stage. We do see that headache becomes one of the most common symptoms. And when you dig deeper, you do find that it is also accommodated by a range of, elevated blood pressure readings here and there. But it is important to pin it down and see what is actually happening there.
I think I'm going to take one more question, and then for everyone else, I know there's still a lot of questions, but we are running out of time. I'm going to take your questions down, and then I will get back to you on that if that's okay with everyone. The last question, cholesterol and hypertension, what is the relationship?
A very close relationship. Hey, you can somehow add diabetes in there. They are all conditions of blood vessels, basically. With cholesterol, we know that it is the thickening of your blood vessels, or a plug that forms inside your blood vessels that occludes the blood flow in terms of how your body needs to work. With hypertension, we know that it's some pressure for somewhere that causes your body to release that chemical I was speaking about earlier on to make your blood vessels to constrict. The two guys can basically lead you into a heart attack, into a stroke, because they both essentially do the same function at the end. The picture is even worse if they are both present in one body, right? And that is why we always say, and that other slide, look at those numbers in totality, because you will know that when you have blood pressure, one way or the other, somewhere along the line, you'll see your doctor giving you something that has to do with, trying to tackle the possibility of cholesterol issues playing up in your life. Or one way or the other, you'll soon realize that the person that's not coping well on blood pressure medication is now being given treatment for diabetes because elevated blood sugar levels are starting to come or pop through, but they are very, very related.
Thank you, Sister Thandi. Sorry, time-wise, we are running out of time. So I just want to say thank you so much to us, Sister Thandi. We really found your presentation informative. And I want to tell all the other members we are going to have these sessions from from July till the end of the year. And our next session is on hyperlipidemia or cholesterol. So we will send you invites. So just keep an eye on your email box. And I hope that you can join us for that session as well. Thank you once again for everyone, and have a very good evening further.
Awesome. Thank you so much for having us this side. Thank you.
Thanks. Bye.